Hello, and thanks so much for joining us today. Welcome to our Health Matters webinar covering coronavirus life and death decisions. I'm Michelle Lavander, Director of the USC Center for Health Journalism. This is a timely moment for us to be discussing how hospitals make decisions about who gets scarce resources, from hospital beds to ventilators to the drugs needed to sedate patients in order to intubate them. This week is expected to be the peak week nationwide for the greatest need for hospital resources, according to projections out of the University of Washington's Institute for Health Metrics and Evaluation. Now, the draconian scenarios we all envisioned seem to be less likely because of the success of shelter-at-home mandates in many jurisdictions, but hospitals around the country are still bracing for tough rationing decisions, and patients and their families and their providers will have to make some tough calls on an individual basis on extraordinary measures. And here to talk to us all about this, we have Dr. Sunita Puri. Before we get started, let me tell you a little bit more about her. Dr. Puri is the medical director for palliative care at the Keck Medical Center and the Norris Cancer Center at the University of Southern California, and the author of the literary memoir, That Good Night, Life and Medicine in the 11th Hour. She completed medical training in the University of California at the University of California, San Francisco, and did her fellowship training in hospice and palliative medicine at Stanford University. She's a graduate of Yale University, where she studied history at Oxford as a Rhodes Scholar. Her work has appeared in the New York Times, the Los Angeles Times, and Slate, and the Journal of the American Medical Association. She's received writing fellowships from the McDowell Colony, U Cross Foundation, and Mesa Refuge. And in 2018, she received the Etz Chaim Tree of Life Award from the USC Keck School of Medicine, which is awarded annually to a member of the faculty who provides humanistic and compassionate care. This webinar with Dr. Puri is offered thanks to the generous support of the National Institute for Healthcare Management Foundation and the Commonwealth Fund. And if you would like to tweet about the webinar, you can do so with the hashtag coronavirus. A word about our format today. We're going to be starting out with a conversation between myself and Dr. Puri, and then we'll turn to your questions, which you can ask through the question and chat screen on your control panel. If you're experiencing technical difficulties, you can also let us know there. And now let's get underway. Dr. Puri, here in California, where you and I are based, the peak day of need is supposed to be this coming Friday. And you're playing a central role as this expected surge hits as ethics chair for the Keck Medical Center and the Norris Cancer Center here at USC. You've been asked to head up the planning for the hard decisions that may have to be made at USC hospitals when it comes to this surge. So first, I wanted to ask you how all these projections are matching the reality on the ground. What are you and your colleagues operating at your hospitals at Keck and at one of the biggest safety net hospitals in the country here in Los Angeles County, known as LA County USC, seeing now? And how does that compare to the expected surge?
So first of all, thank you so much, Michelle, for having me back. It's a real honor. And I'd also like to thank Ryan White, who is behind the scenes making all of the technical aspects of this webinar possible. I hope everybody in the audience listening in is doing well and is staying safe and healthy during this really difficult time. And to your question, Michelle, so it is true that there is an expected surge that's potentially supposed to start this Friday, from what I have heard and from what colleagues and I have been discussing. Right now, though, hospitals in Los Angeles, where I have colleagues that I've been in touch with, have not reported the sort of numbers that we may be projected to see quite yet. I hope I didn't jinx it by just saying that, but at least so far, we're not seeing overwhelming numbers. And I think it might actually be useful to define what a surge is and then what it might mean vis-a-vis things like resource allocation. So I don't know if there's an agreed upon definition of what constitutes a surge in coronavirus cases at the moment, but I think what it's meant to, what it kind of implies is that we might come to a place where there's way more patients than resources. But that said, the numbers right now on the ground, at least at Keck and County and some of the other hospitals in the area, we're not seeing the sort of numbers where we're needing to make decisions about resource allocation right now, and I really hope it stays that way.
Thank you. And if we get to that moment, and I hope we don't, and I know you do too, what are the factors that your hospital and others around the nation have to think about and consider in making decisions on how to allocate resources? And what
Yep.
are the broad principles that are being followed? And who makes those decisions? Is it a state decision, a hospital by hospital decision? And how are you dealing with this at your own hospital?
So that's a great set of questions. And I think there's a lot of fear right now amongst medical professionals and the public about what resource allocation would look like, who would make those decisions, and how they would be made in the most equitable way possible. So I think for journalists to know, first of all, right now, to my knowledge, there's no hospitals in Southern California that are needing to make resource allocation decisions, AKA rationing. I don't really like the term rationing, so I'm going to use resource allocation throughout this webinar. I think there's a couple principles that form the foundation of the policies that many hospitals around the country have developed in anticipation of resource allocation situations. The first is that we're kind of in that situation, you need to shift from person-centered ethics to population-centered ethics. And what that means is that, generally in medical practice, we are looking at an individual patient and applying principles of biomedical ethics like autonomy, beneficence, non-maleficence, and justice to make decisions that are in that patient's best interest. When we're in a time where resources are limited and patient need is very great, we shift to what we call population-based ethics. And what that means is that we're interested in providing resources to patients who are most likely to survive their time in the hospital. And that's a very, very big shift in the thinking of physicians and in the expectations the public might have of doctors and nurses during the time of shortages. So I want to acknowledge that's a big shift and that it's uncomfortable for everyone involved. I can speak as a physician and somebody who practices ethics that even though I can rationally know that we're shifting for a reason, it doesn't make it easier to apply that logic on a day-to-day basis if we ever get to that point. So that's point number one, is that we would be using resources for the greatest good possible, meaning we want the greatest number of people to survive. How that breaks down into policies is that at least at Keck and a number of other hospitals around the country, we are taking the decisions about this away from the physician providing care to the patients. That's another very important thing to know. So headlines about doctors needing to make excruciating decisions about which patients get what is not entirely accurate, because a lot of the policies are taking the decision out of the doctor's hand and putting it into the hands of either a triage officer or a triage committee. That committee is generally made up of people from a variety of disciplines in the hospital. It may include someone from hospital administration and ethics. And we would get the information about patients coming in from the attending physician taking care of that patient. The information we ask for are things like, what are the health issues that this patient already has? So for example, are they suffering from diabetes, heart disease? Do they have stage 4 cancer? What are their issues they're already living with before they got sick? And I want to clarify that getting sick in the resource allocation scenario does not just mean getting COVID. It means getting anything, any disease that would qualify you potentially for use of that scarce resource, whether it's a ventilator, an ICU bed, advanced cardiac technology, or whatever. And the information, in addition to what they're already living with, that we want is information about how their physiology is at the time they've come into the hospital. And we use something called a SOFA score. a sequential organ failure assessment score that takes into account things like how their liver's functioning, how their kidneys functioning, what their mental state is, how many platelets they have, pure physiologic markers. And we put that information together with their expected life expectancy from whatever issues they have coming in. And the triage committee then assigns a priority score to the patient. It doesn't mean that if somebody is not the highest priority for the ventilator or whatever it is, that we just say, sorry, there's nothing we can do for you. And I think that's another nuanced part of this discussion that would be so helpful to relay to the public. It doesn't mean you either get a vent or you don't. It means you may not be the highest priority for a ventilator, but we will still take care of you. We will still provide the best medical and nursing care, including symptom relief and using medications and machines that we can use outside of the ICU to take the best care of you. And every day we reassess how patients are doing in the ICU, how patients waiting for an ICU admission are doing, and we recategorize priority of the patients based on that. So that was a really long answer, I apologize, but I think the takeaways are that we are not, at least at CAC, we're not looking at things like age. We're not taking into account your differently abled status, your social status, your race or ethnicity. None of that matters to the triage committee. What matters is what diseases you've been living with and how sick you are when you come into the hospital. And that is actually how many, many academic centers across the country are practicing resource allocation, with the caveat that I don't know of anybody actually needing to use the policy right now.
Thank you so much. So, this decision-making process seems so important, and yet I think it's a little bit of a black box for a journalist trying to understand, is their local hospital or healthcare system doing a good job? Have they done the planning, the kind of practice perhaps that needs to be done? So what questions should journalists be asking in order to assess where their local healthcare institutions are with all this?
Yep, that's a great question. And I think there's so much variation in what hospitals are able to provide around the country. Michelle, you and I had talked about big academic centers in big cities being differently equipped to respond to COVID and large number of patients compared to smaller hospitals that might not be as well equipped to respond to a large number of patients who are very sick. I think an interesting question to ask of a hospital you might be talking to is, how many patients with COVID have you had? How many patients without COVID who are still seriously ill and need, for example, ICU level technology, how many of those patients do you have? Have you encountered any obstacles in their care? And if so, what sorts of obstacles have you encountered? And this could be asked of staff physicians, it could be asked of administrators, people who are really in the know about what the day-to-day challenges have been. They may or may not be open to discussing in detail what their challenges are, but I would anticipate many of the challenges to be similar across the country. So shortages of doctors and nurses who are equipped to take care of patients who are critically ill. That's something that many hospitals are facing, either because healthcare workers are getting sick themselves or because there's just not enough ICU trained physicians in, for example, a rural area to handle the influx of patients that they might see. I think also asking what sort of response plan the hospital might have if they get to the point where they have a lot of patients and those obstacles to care are no longer theoretical, they're real. I think it would be interesting to ask, especially of hospitals that are more isolated, what sort of discussions have you had with other hospitals that might be bigger tertiary care centers that might be able to absorb some of the patients if you get overwhelmed? Have you had those sort of partnerships? And I think even just the question of, do you feel prepared? And what does that mean to you? If you don't feel prepared, how are you addressing that? I think those are some of the questions I would recommend asking, knowing that some hospitals may not be as forthcoming about answering those questions in detail.
And I just want to touch on something about personal protective equipment, because
Yeah.
it seems like it would be hard to really get at whether the providers are getting the adequate protective equipment that they need. How might you get at that?
I think asking directly about that what are your supplies of personal protective equipment like right now? Do you have a plan in place to get more as the numbers of patients go up? Is it a concern for you? I think those are some of the questions to start with. And I think you're absolutely right that PPE shortages are part of what I would consider a scarce resource. Because if you don't have that, then doctors and nurses really cannot do their job. So you're kind of seeing a double whammy there, a shortage of resources for PPE leading to a shortage of care providers.
And I also wanted to get your insights about whether the media may sometimes be asking the wrong question about who gets focusing on who gets ventilators, who gets hospital beds, the rationing kind of framework that we're hearing, and who makes the decisions about resuscitation of patients. Are there misconceptions out there about how hospitals are already making these decisions on a day-to-day basis about things like extraordinary measures and resuscitation orders?
hmm So great question, and I'm sure that's on the minds of a lot of people listening here, and on the minds of people in the just in the public. I think writing very sensitively and carefully and in a nuanced fashion about resource allocation, shortages, and about things like resuscitation orders is really important because my general sense, and I'm going to make a big generalization here, but in my experience, I've certainly encountered a lot of suspicion of the medical system from different groups. And I think when we write in broad terms and not in nuanced terms about things like ventilator allocation or resuscitation orders, we might be inflaming the suspicious attitude that some people already have towards the medical system, even before COVID, feeling like they may not be a priority to get the right sort of care. And so writing in really general terms about what allocation of a resource means might actually make that suspicion worse. So to address resuscitation orders, because I think there was a Washington Post article about some hospitals really saying that if you come in with COVID, we will make you a do not resuscitate patient. I want to take a step back and talk about what resuscitation is, because in medicine, we can use that in a variety of ways. If somebody comes in dehydrated, we can give them a lot of fluids through an IV and call that fluid resuscitation, for example. The resuscitation that's referred to in that article and that's become the subject of debate is really what we call advanced cardiac life support, so ACLS. That includes chest compressions. It may include defibrillation, which is shocks to the heart to get it out of a bad rhythm into a life-sustaining rhythm. It often includes putting a breathing tube in a patient's throat and connecting them to a ventilator. In general, resuscitation is not what we see on TV. There was actually a New England Journal study, I believe this was back from the 90s, but there have been more recent ones, where they actually compared the success of resuscitation on television shows, medical TV dramas, to the success of resuscitation efforts in real life. And by success, what they were measuring in that study was whether the patient whose heart had stopped and they died, essentially, if they underwent resuscitation, would they make it out of the hospital? That's what they were looking at. And I believe for the TV shows, the success was around 88%. So 88% of people who were so sick that their heart stopped and they died, and then they went through CPR and shocks and being on a breathing machine, 88% of those people walked out of the hospital being who they were before. In real life, we kind of divide things into people who have a cardiac arrest outside the hospital and in the hospital, so a witnessed versus an unwitnessed arrest. And the numbers, the percentage of people who survive to hospital discharge with being themselves or some semblance of themselves is around 10 to 15%. So very, very different than what we see on television. And unfortunately, I've been in a number of situations where I'm having a meeting with a family about resuscitation status, and people will bring up shows like Grey's Anatomy and say, well, I see it's successful there. So I bring up those divergent statistics because the media and the television shows especially can inform what people expect of doctors generally, what they expect of resuscitation in particular. So knowing those statistics and knowing that to perform resuscitation, it's actually a very labor intensive process. We have multiple doctors in the room, many nurses, pharmacists, anesthesiologists, or other critical care doctors who manage people's airway and make sure that they're on a ventilator as soon as possible. And there's a number of other people who show up to really make sure that they do everything they can to get the heart rhythm back. And in resuscitation, that's another important thing. Getting a heart rhythm back does not mean the patient is going to necessarily walk out of the hospital. But all of that effort is made even to get a heart rhythm back. And in the setting of COVID, where we know if somebody gets so sick, usually from their oxygen levels dropping lower and lower because their lungs are under siege, if their heart stops because their oxygen levels are so low, the chances of bringing them back, either just with a heart rhythm or as themselves, are exceedingly low in the setting of COVID, from what we know from studies in China and in other parts of the country right now. So when some hospitals are talking about a mandatory DNR or a do not resuscitate order for patients with COVID, what they're taking into account is the exposure of many, many healthcare professionals to a patient who's very sick. And COVID can be spread very easily through respiratory secretions, many of which we are directly encountering when we're doing chest compressions and putting someone on a ventilator. And so limiting the code status option for patients with COVID in many hospitals thinking is because they want to make sure that they protect the staff so that the staff can continue to do their best for as many patients as possible. So it's again thinking from person-centered ethics to population-centered ethics. If we need to save as many people as possible, we need our teams to be healthy enough to do that work. And I understand absolutely why this is a controversial decision. But I think the thinking behind it is not with the intention of being malicious or denying people care. It means that the hospital would still provide all necessary measures to keep someone well and alive. But if all of those necessary measures still, if the patient gets all of this and still ends up having the stopping of their heart, then that says something also about how sick the person is and about how likely they would be able to make it out of the hospital. So I want to also distinguish between a DNR, meaning do not resuscitate in a specific circumstance of the heart stopping, versus some people's thinking that a DNR means just don't take care of the patient. And that's absolutely not true. It's a big misconception I encounter all the time. DNR does not mean do not treat. DNR means do everything you can to treat someone, but if their heart stops and they die, to allow that to be a time of grace and dignity, free of pain and suffering to the extent that we can provide that, rather than putting them through a medical procedure, ACLS, which may not bridge them from a place of sickness to a place of health.
And Dr. Puri, you talked about how we all see these television shows that show these very dramatic rescue scenarios. And I think I certainly assumed, and many people probably do as well, that it's up to the patient and their family to decide whether they want to be resuscitated. But you shared with me that even before this pandemic, it's been a much more complex situation about who has that decision-making power. Walk us through that a little bit.
Certainly. So I have always found it interesting that we pose to patients and families the question of whether or not they want to be resuscitated. And I have seen this done in ways that do not reflect the nuance that the conversation really should. So, what do I mean by that? CPR was really kind of invented for young, healthy, or people, sorry, not just young, people of any age who are otherwise pretty healthy and get into a situation that might be reversible with CPR. It's again thinking about CPR as a bridge from a place of sickness to health. It was not necessarily created for people who have, for example, end stage cancer or very end stage heart disease, things that may not be reversible. And so acknowledging that CPR might actually be painful and full of suffering and not actually help people to reverse the reason why their heart stopped, that's a very nuanced set of concepts. And to boil that down into, a resident asking a family, do you want us to push on his chest and try to restart his heart if that happens to him? And I've seen conversations done that way. I've also seen families being asked, do you want us to do everything or do you want us to not do much? And those kind of binary questions don't reflect, again, the nuance of what it means to perform CPR and what outcome you're looking for. CPR is a violent procedure. If we do it well, we're kind of pressing on the chest with our full body weight about 100 times a minute to simulate the work of the heart. What we're doing it so aggressively for is to make sure that the brain in particular is getting as much blood flow and therefore oxygen as possible. But in that process, when we do chest compressions well, we often break ribs. Broken ribs can puncture lungs, among other things. It's not a benign procedure. And so when we think about offering it to people or having a shared decision-making conversation about it, I think what's so important is to put into context what it would mean for someone at their stage of illness and to ask them what they would be hoping for and what would be most important to them if, despite all of our efforts to keep a disease process at bay, their heart still stopped and they died. And I think using stark language, being very honest and clear, and yet also compassionate is pretty much the only way to have these discussions. I think when we ask things like, do you want us to do CPR and save someone's life? We're not actually getting at concepts like quality of life or our recommendation as physicians about whether or not CPR would benefit our patients. And we leave something that huge a decision in the hands of patients and families who may not be able to really exercise informed consent if we don't give them the full scope of information regarding the risks and benefits of CPR and whether it would actually help them in their particular situation.
And if a doctor in a ER encountered a patient who wanted to be resuscitated or whose family wanted that, and this was pre-COVID, and the doctor's assessment or the team's assessment was that this patient would not live for another day because of all the other things, going on with their health.
Mm-hmm.
With their and there was a lot of, I don't know if it comes down to if it's a resource thing where that ER doc might look around and see what else is going in the ER, or if it's just a matter of a realization that that patient, had hours or a day or two to live. I mean, pre-COVID, would that or could that doctor or that team make a decision about what would be best that might surprise, the ordinary person, to know that those decisions, those calls are also being made by the medical team, even in a time that's not a pandemic?
Yeah. So I think, first of all, decisions about resuscitation, the scene you mentioned in the ER, I don't think resources have anything to do, pre-COVID in particular, with our recommendations around CPR. In the COVID era, because of exposure for healthcare professionals, it's a little bit of a different scenario. Um, but really, for years before COVID, just, CPR is a medical procedure. And just like we can sometimes say this person is too sick to go for a surgery, the surgery would probably kill them instead of help them. It's the same sort of logic with CPR. And this is not what we are taught in medical school. I didn't learn this really until I was taught by an incredible attending physician of mine in my palliative care fellowship that sometimes a code or, CPR and intubation, people may not be candidates for that. And the key is to explain why and to put it into context. I've been in many family meetings where patients or families tell me that their loved one, who at that time is really sick, is a fighter and would want everything done. And when I have the luxury of time to really explore that, I ask them to tell me, what does it mean to your loved one to be a fighter? Tell me what that looked like for him. When you say you want me to do everything for your loved one, can you tell me what that means to you and what you envision something like CPR doing for your father, for example? And I think those are the sorts of things, kind of understanding where people are coming from and what they're hoping for, and reconciling those hopes with either the utility or non-beneficial nature of CPR as a medical procedure is the art of having a conversation about code status. It's not just saying, like, we would never say to someone, do you want us to do this risky surgery or not, if we knew that the surgery would be more likely to take the person's life than to save their life. And it's the same logic with codes. We just don't portray it that way. And I think we put a lot of patients and families in a hard position. I've been in a number of situations where I have recommended that because someone is really, really sick, going through CPR would not be in their best interest. And a lot of the times, their family will come to me later and say, thank you for not asking me to make that decision. So far from being kind of paternalistic, it can still be a process of shared decision making. But I think we as physicians need to learn to make our recommendations for such a critical decision that could involve how somebody dies, right? And where they would die and what that would be like for them and their family. So having that courage to step forward, step toward the discomfort of talking about a DNR rather than retreating and saying to the family, well, what do you want us to do? I think having that courage is something that I try to train my students and my fellows and residents to really have, because I would have done things so differently as a resident and a fellow if I'd had that training before. I put patients through a lot of suffering by asking their families, do you want me to do chest compressions or not, when I was a trainee, because I didn't know another way. So I think of teaching these conversations as giving my trainees the tools to really mitigate suffering in a different sort of way. I feel like my answers are super long. I apologize. I don't mean to be
This
on
is
a...
really wonderful. And Dr. Puri, I think that you touched on something I want to follow up on, which is, you talked about conversations with patients, but there's a whole other question of conversations within families. And because,
Yes.
and I think this is probably uniquely American, so much of what we're talking about and journalists are writing about is, are there enough ventilators? We're not really asking the question, is a ventilator a good idea for my mother or my grandmother? And what would that really mean to be on a ventilator? You've talked about
Yes.
just all that's involved from the healthcare provider's perspective, but for the patient, it's a pretty, highly interventionist, brutal, uncomfortable. You have to be sedated to be intubated, because otherwise you wouldn't be able to withstand it. And complicating all this, as I know you're familiar with COVID, it's not like the family can gather around that patient to have that conversation. And so if those conversations are not had ahead of time, it seems like we're in a scenario of somebody who's alone and having to make decisions remotely over the phone, and so on. So what should what should people be thinking about? What questions should they be asking rather than just saying, "Are we a fight? Is grandma a fighter or something?"
There's so much to unpack, and that's a great set of thoughts and questions. And I think to start with kind of the conversations to be had now, I think COVID has given us a very strange gift in forcing people of all ages with whatever chronic medical problems they may or may not have to start to think about what they would want for themselves if they got really sick. Because the data we've seen on COVID is that young people, older people, people who were previously healthy, and people with a lot of issues, all of those groups have succumbed to COVID infections. So, really, nobody of any age is spared needing to have this discussion. I think the discussion content is not different than in the pre COVID era. And yet, many people don't have these discussions because, understandably, the contemplation of illness and mortality is really frightening. It's not a fun topic to approach. But some of the questions I recommend that people start with are, what is the story of my life? Who are the people that make my life meaningful? What are the sorts of activities that define my life? If I were to be really sick and go through interventions that may never allow me to go back to the people I love or the activities I love, how much suffering would I be willing to go through, possibly for the benefit of not having those things in my life anymore? Who would I want to speak on my behalf if I couldn't advocate for myself? Who would I not want involved in decision making if I were really sick? When I think about the future, especially if you're living with an illness already, what are the things that worry me the most? What are the things I've found some peace around? I think those are some of the really basic questions to start with. And I think where looping in your doctor or your other healthcare providers is essential is to ask them, if I got really sick, if I got COVID, given what you know about me and given my health history, what are your thoughts on how many measures I should go through? And I think asking doctors is actually really helpful because when we're not a part of the discussion and yet we end up having to make decisions on behalf of patients we might know really well, but we've never had that discussion with, it becomes a little bit more difficult to have that discussion in the throes of a lot of emotion and an emergency situation potentially. So moving those discussions early when you're clear of mind and can think things through, I think that's the gift we give our families and our care providers because they can hear from us what's important to us. I want to distinguish that conversation from what we put in an advance directive, which I think can be quite reductive. So advance directives vary in form. Sometimes lawyers make them up, sometimes hospitals have a form they give you. What an advance directive should include is the name of your medical surrogate and, one or two alternatives or alternates. It should include questions about organ donation, whether you would want that. It often includes questions about resuscitation. Would you want to go through CPR and being on a ventilator forever? Would you only want a trial period of that, or would you not want that at all? Those are very simplistic questions. We need to do them, but they don't always, the context can vary so much that someone who says they want everything done for them and they filled that out, before they got a widespread cancer, the decisions that they would make might be different. And it's more about the conversation that precedes the decisions. Because if someone says to their husband, for example, I know I have end stage lung cancer. If I get really sick, I would want to be home on hospice. At least you know that. It's a conversation that's more concrete than just about, whether you would want to go through CPR or not. And that's really where the beauty of decision making can be, is saying overtly to your loved ones and your doctor, this is the sort of person I am. This is what's important to me. I would only want medical interventions that would help me get back to the place where I could ride my bike every day or enjoy food or even just sit and be with my family, even if I couldn't do anything because I was paralyzed or because I was so weak. Knowing your values helps us to guide in decision making, and that conversation helps a lot more than just check boxes on an advance directive. There were other parts to your question that I missed.
Well, I want to go on to
Sorry.
another one because I'm looking at some of the questions that people are sending, and we're going to turn to those in a moment.
Hmm.
But one of the things I wanted to ask you about is some comments that have come out of the disability community,
Yes.
and some concerns about whether someone who's disabled is going to be relegated to the end of the line in rationing decisions. And I'm going to quote from one activist who was writing in Vox recently, who said, even the notion of quality of life as a measurable standard is based on assumptions that a good, healthy life is one without disability, pain, and suffering.
Hmm.
And that she, had all those things and still felt her life was obviously worth living and didn't want to be, have a decision made sort of on her behalf that she would never have wanted. So how do you
Yeah.
respond to some of those questions that are coming up from the disability community?
So it's interesting, I had a conversation with a dear friend of mine who's a pediatric neurologist up in the Bay Area, and he takes care of a lot of patients with cerebral palsy, which, as you know, can take a variety of forms. People can have different levels of function, but there can be a bias that someone living with CP doesn't have a good quality of life at baseline, which is exactly what the concerns of the disability community are, as reflected by the quote you read. I think what helps a lot in resource allocation decisions is that we really try to stick to the physiology and what the body is showing us at the time of a serious infection that might need a scarce resource. We really try to stay away from all of the other factors in a person's life, um, except where their life expectancy might be altered based on, for example, advanced heart disease. But disability is not a medical condition that limits life necessarily in all cases. One of the things my friend and I discussed was the even higher importance of people who are differently abled to actually write down their wishes and write down, explain what their quality of life is and what it means to them. Because in the absence of that, I can see even well intentioned providers wondering, what sort of life are we bridging this person back to? And without knowing those patients, as for example, my friend knows his cerebral palsy patients really well, without that knowledge of the patient and who they are and how they've been living their lives, sometimes physicians can make assumptions, and that's precisely why this community is very concerned. I think having the right advocates, writing down your wishes and explaining, this is what my day to day life is, this is what I'd like it to be. I think that can be invaluable in the sort of cared goal discussions that people can have with their providers, even in the setting of an emergency. But I would say it's even more important for those communities to be very clear about what their wishes are and to use that as an opportunity to dispel the idea that their quality of life isn't as good as someone else's quality of life.
I'm going to ask you one more question before I open it up. And everybody, you have the chat, the question field in your control panel where you can send us questions for Dr. Puri. So, in addition to being a palliative care specialist and someone with a lot of responsibility on ethics at the USC hospitals, you're also an author and a beautiful lyrical storyteller. So tell us what some story ideas are that you think journalists should think about, or some approaches that maybe you're not seeing as much of as you'd like to in the media.
That's a great question. I think you asked me this on our last webinar too. And I think, one of the things I would love to see, and this isn't quite related to this discussion, but portraits of the people who have died, either of this disease or the healthcare workers who have died on the front lines. I know of people who were in their training back in New York who died, and there's been no coverage of them. And I think that there's something really sad about overlooking those populations and telling their stories. So that's definitely one thing I would love to see, even as a series that someone can write about different providers and different people who died in the line of fire. Um, I also think that having, for example, a spotlight on how people are approaching goals of care discussions or filling out their advanced directives now in the context of COVID and how this has changed their approach to talking with their families about what's important, or how it may have not changed their approach. I think that would also be a really interesting story I'd love to see written.
Thank you. I'm going to turn now to folks' questions. We have one from Aisha Sander, who says, I'm reporting in a rural area and some
Mhm.
hospitals and clinics are in danger of closing since non-essential procedures and appointments have been canceled or
Yes.
postponed. How does the for-profit hospital care model impact the pandemic response?
That's a great question. And I think that that model, if you're reporting on hospitals that stay afloat by offering elective surgeries, for example, I think this is a time where that model may need to be questioned. And I think it's been brought into question for other reasons before. But now that hospitals are seeing much of their revenue that they use to provide other more essential services, they're seeing that being challenged. Now's a time to maybe rethink how they're making most of their money and whether there's other ways to stay afloat that don't just involve funding from sometimes non-essential surgeries and elective procedures.
And we have a question from Lynn Bonner, who says, if pre-existing conditions are part of the resource allocation decision, doesn't that put African American patients at a disadvantage considering higher rates of high blood pressure and diabetes?
I think, when we talk about pre-existing conditions, what we're really looking at is expected survival with a pre-existing set of conditions. No one condition is kind of singled out, it's the multitude of things together. I do think there is an impact on underserved communities of all backgrounds, racial and socioeconomic, because these are people who, A, may not have much access to the medical system in the first place, which is a tragedy, or B, may have a lot of suspicion about what the medical system has to offer and therefore opt to stay away. So I think as we've seen, Black communities are already disproportionately affected by COVID, and I expect that that may continue to be the case very sadly because they may have diseases that could have been under good control if only they'd had access to the right medical care. I think it's always in these situations where inequalities become exacerbated. And I think we're sadly going to see that. And kind of like the answer I just gave, I think this is an opportunity to really rethink the vast disparities that we have in this country around healthcare and well-being. But I do want to emphasize that someone having diabetes and hypertension alone doesn't mean that their outlook and the number of points we would score for their life expectancy would be significantly different from, for example, somebody who has some degree of heart disease. So there is some, if you, for example, have end stage cancer, that puts you in a very different category than somebody with diabetes and hypertension who may not have the long-term consequences of diabetes and hypertension. So I think there's a lot of nuance in how we make that determination that isn't just they have diabetes and hypertension, they're not going to live very long. There's a lot more that goes into prognosticating or thinking about someone's lifespan. Nonetheless, we do know, I know from my hospice work that I did a few years ago that I covered mostly Black and Latino communities, and the patients I would get there for hospice care were significantly younger than patients that had more wealth and different backgrounds living on the coast in California. So we know that at baseline, and I really hope this will be an impetus to try to change that, whereas we should have changed this years ago.
Thank you. We have a question from Katie Butler, who says, shouldn't we be asking hospitals what survival statistics are like for people who are mechanically ventilated? The majority are dying Are we consigning too many to ICU versus hospice? And have journalists over-concentrated on two panaceas, testing of the worried well, which Katie calls pointless, and the disappointing results from ventilation?
So I want to give a shout out to Katie. Katie Butler is the author of some beautiful books about living well and dying well, and I can't recommend them highly enough. Her latest is The Art of Dying Well, and her first book was Knocking on Heaven's Door. So hi, Katie. I'm glad you got to join. I think survival statistics are important, and I think just as important as that is how are people leaving the hospital? In what condition? And we have specific quality of life indices that we can use and track with people who survived a hospital discharge. I think one thing to note also that would be interesting to ask hospitals is how long are people staying on a ventilator? Because we know generally the longer you're on a ventilator, the harder, more challenging your recovery is going to be, which impacts quality of life. So ventilation days in patients with COVID tend to be longer than ventilation days, for example, with someone who might have some degree of COPD and gets pneumonia, a bacterial pneumonia. That person may generally have a little less time on the vent. What we're seeing in COVID is people have a long time on the vent. So the range of days that people are on a vent at a particular hospital might also just be interesting to know to see if it matches practice patterns or outcome patterns in the region that you're in.
And we have a question from Andrea Gallo, who says, when we talk about decisions being made about resource allocation, is it individual hospitals who make those calls, or does that possibly fall to government officials directing hospitals to implement those types of changes?
I think that varies a bit state by state. I've heard that in New York, I've heard from a colleague there that there is perhaps a little bit more guidance from the state around loosening certain laws so that physicians can make decisions they may not ordinarily make. In California and just across the country, actually, what I really want to emphasize is a lot of thought went into these documents for resource allocation. Many of us in ethics looked at pre-existing documents. So in 2015, New York actually issued a statement on resource allocation of ventilators, in particular as a response to the H1N1 epidemic. The VA did the same. So there were pre-existing guidelines for either disaster medicine or specifically the use and allocation of ventilators if we get into another H1N1 situation. So many of the current policies are actually based on well thought out policies that existed before COVID hit. And some of the similarities really include using the SOFA score, thinking about prognostication and adding points based on it, someone's life expectancy, even without COVID or another disease bringing them to the ICU. Different policies have different things to say about age. For example, there are some institutions that take age into account. There are other institutions that add in a blanket DNR for all patients coming in with COVID. So there's some variation, but the core principles of all of these policies, whether coming from a state government or not, are that number one, this is population-based ethics, and number two, we do not want the frontline clinicians to be making these calls. That is the purview of the triage team, both to be a little objective and to be consistent in the standards we're applying for resource allocation, but also to protect the physicians on the front lines from needing to make that call. And I think that's where nuance about that is going to be really helpful in the writing coming out, because things like doctors need to make painful decisions. Actually, the whole point of having these documents is to prevent frontline doctors from having to make those decisions. Whether that's coming down from a state or not, I think that varies state by state, but that would actually be an interesting article to write too. In what states are certain protocols about resource allocation coming from the government, and in what states are they not? And how do the policies look differently based on that factor?
And Dr. Puri, we're seeing a debate right now playing out in public about who has the authority to reopen states. Who has the authority to dictate those terms? I mean, does the state have the authority to impose that on hospitals, or who really has the power there?
I'm not sure that the state should have authority to impose those standards on hospitals because I think there's a great variety in thinking at different hospitals. There's a great variety in how practice patterns are. I also don't think that the state regulating medical practice has ever panned out very well, aside from having laws that are pretty obvious, like don't discriminate against differently abled people or, don't engage in euthanasia, right? Those sorts of things, I think absolutely we need laws in place, we need governing bodies to guide us. But I do think hospitals in different settings should be allowed a bit of autonomy in making decisions and policies based on their resources. Smaller hospitals may simply not have enough staffing to have a whole separate triage committee. There may just be one person who has to make these calls. So I think being rigid about what hospitals must do and must not do is very constricting in an era where there's already a lot of anxiety in hospitals.
And we have a question from Santori Chamley who says, how much transparency is there in the allocation of resources to mitigate against abuse of patient rights?
So, in terms of transparency, at least what we plan to do at our hospital should, again, if this comes to pass, and again, I don't know of any places where this is currently coming to pass. But in terms of transparency, my practice has always been to be transparent about a situation that a hospital might be in and to be transparent about how that might shape the sort of choices people have. There's a great guide from an organization called Vital Talk about how to have some of those difficult discussions with patients, especially when resources are scarce. When I first read the language, I'll be honest, I was a little taken aback by how straightforward they recommended being. And I'm like very straightforward as a palliative care doc and as an ethicist. But in thinking about it, I think honesty really is always our best policy, and training physicians and other staff on the language to be both transparent and also compassionate, and to not frame things as either you get a resource or you don't. The question is, what sort of care can we and should we provide you given the constraints on the system? And the more that people know, and I think this is where the power of truly nuanced storytelling in the news can be very helpful, is to help people know triage decisions are not about giving you everything or giving you nothing. It's about using our resources to help the greatest number of people live, but to continue to treat with the best possible care everyone who walks through the door. That's what I think is a little bit missing in the coverage right now. And I think to speak to transparency, those are the kind of stories that will prepare people in case we experience a surge, in case we have to allocate resources, for them to kind of know what to expect and what questions to ask.
We have a question from Indira Rojas, who's in Venezuela, and she's asking about maybe some specifics about these moments where there just aren't enough resources. She said, "What worries most is the lack of how the lack of resources will have an impact on the ability to save lives. What specifically can doctors do when faced with intensive care units full of patients if there are no resources to care for them? What is the criterion for deciding who to treat in a respiratory crisis," which you've touched upon,
Yes.
and if there's more than one patient in the same condition?
So again, I want to be extreme. I'm going to just keep saying this, right? It is not up to the doctors on the front line. In the best case and most well thought out scenarios, we will be prepared with triage officers or triage teams. So I really want everyone to stop thinking that frontline doctors are making these decisions. Every hospital should be preparing now with triage committees, triage officers who will step in to make those decisions, again, based on things like the SOFA score, the sequential organ failure assessment score, and based on people's other medical conditions and how they limit their life expectancy before they get sick with COVID or before they get sick with anything that might require them to go to the ICU. I think it's extraordinarily unfair for doctors to have been put in the position they were put in Italy, for example. So we know it's happened. What we're trying to do now is be proactive in having a plan in place so that it doesn't fall to the person who is on the front lines to make that hard call too. Will they have to make those hard calls sometimes in an emergency? Absolutely. This is not an ideal world. And we know from practicing medicine that things rarely go according to a simplified plan. So a scenario I could see happening is someone comes in extremely short of breath, and the physician either has to call the triage officer or just intubate that person right away. There are times where those patients will get intubated and then the triage committee steps in. So I think the name of the game is having an organized response, but also some flexibility to allow for the fact that everything's not going to go according to plan just because we might have this perfect plan in place. So I hope that answers your question. I mean, I think in places like Venezuela, which are, one of my colleagues actually is Venezuelan, and we've talked a lot about resource limitation in Venezuela compared to the United States. And I think you could say that for any country outside the United States, including where I'm from in India, that there's just not the same number, for example, of ventilators. And I think knowing that means having a response ready and training everybody in what that response is going to look like is even more important.
And we have a question from Kathy Jean Schultz, who says, in your experience, are administrators involved in resource allocation influenced by public pronouncements about, the importance of economic considerations versus patient concerns?
So administrators, I can give you the example from Keck and from what I know of other places that I've been in conversation with. To my knowledge, administrators have not been part of this process of determining how to allocate resources and whether there's any economic considerations. I can't speak for everywhere, but I can speak for a lot of places here in LA that that's not at all part of triage decision making. Administrators have to sign off on the policy. So for example, the policy that a colleague and I wrote for Keck had to be vetted by the administration. So they had to see that this is the policy proposed and be okay with it. And they were completely okay with what we wrote. And at no point was any consideration ever given to economics or how much it would cost to treat one patient or another. This is simply about using resources to achieve population-based outcomes instead of patient-based outcomes when we're in a true crisis. But I think, the other thing we wrote into our policy that I think is in numbers of them is that our hospital needs to make absolutely every effort to avoid getting into that situation. And I think that's a key part of the policy because no one wants to have to be in that situation. We certainly don't. So it's part of the obligation of administrations actually to do what they can regarding staffing, ICU beds, outsourcing, or getting locum tenens folks to come in to help staff, things like that. The obligation is on the administration to protect the hospital and patients from ever getting to that point. So that's really how I see the role of administration in this.
And we've seen how this crisis is both exposing the weaknesses in our safety net system and giving some added urgency to making changes. For example, in primary care, talking about not reimbursing people per doctor visit, but really for keeping people healthy. I mean, that's been bubbling for a long time, but there seems to be some progress around that. So Lyle Muller has a question that's related to something you addressed earlier, which was this idea that some hospitals are going empty because nobody wants to go for non-essential treatments.
Yeah.
And is there a discussion percolating up as we see these kind of crises for rural hospitals in particular about different ways, different models to what we do now, our current for-profit model for hospitals? I know it's a big question, but it seems like an important one right now.
Certainly. And, I want to be honest that that sort of information is not really discussions that I'm a part of as an ethicist. So I don't know that I can speak to how healthcare systems will be funded or thought of in the future based on this? I do think it's an important question worth asking, and I think that would be an amazing topic for a story.
Thank you. And then a final question is from Nancy Newkirk, who says, how do you balance, as a palliative care specialist, hopefulness and not sort of predetermining a trajectory of outcome? Like, how do you balance, what you talk to your patients about? And she says, I want to know more about achieving relief and supporting treatment while avoiding a scenario of suffering and dying in distress.
So I want to be real clear also that in this webinar, I'm really wearing my ethics hat, not my palliative care hat, because I think the role of palliative care in COVID is very different than the role of ethics. So I think I might have said that before, but in answering your question, I really want to emphasize that again, because palliative care is not generally engaged in discussions of resource allocation. In fact, I think a lot of people would be more suspicious of us if we were. So I want to be real clear about that again, that I'm answering these questions as an ethicist. And the question again was around, sorry, I said that and I forgot the question, but it was about balancing.
I did get the impression that was focused on not so much resource allocation, but more the conversation with patients. How do you have a conversation with them that will not give a false sense of hope, but also make clear what likely outcomes are when you're dealing with someone who's very sick with COVID?
So I will put my palliative care hat back on. I should have had like two hats here, which I could interchange, but I think your question is super important, and it's one that I get asked a lot. So as a palliative care doctor, I think one of the hardest things to learn is how you balance hope and reality. And I think one of the ways that I approach it is to say very early in the conversation that these are tough discussions, and they're discussions I have with everyone I'm taking care of. Because part of doing everything possible for you means having a conversation about your hopes, the medical facts of what you're going through, and how we can reconcile those two moving forward. So normalizing it, I think, is hugely important emotionally for families and patients, because otherwise having these discussions generally feels like something dire to them. Like, why are you talking to me about this? The truth is we should be talking to everyone of our patients, whether you're a palliative care doctor or not. And I think the best discussions actually come from listening very carefully, asking questions, but really listening to the responses to hear what people are hoping for. And I think hope exists in a couple of domains. We all have hopes for our lives, regardless or aside from our illness. And then we have the reshaped hopes based on the illness. And then I can talk a bit about how those hopes may need to be refined further based on the changing medical condition that somebody may have. And I think of these discussions as not a one-time thing, they're an ongoing thing. And this is why involvement of palliative care very early in the care of patients with COVID, or in the care of patients who are seriously ill and living with a disease that might have serious impact on their day-to-day life, from symptoms or disability based on treatment or also on symptoms. Keeping those discussions going early and continuing will allow me to really navigate the dynamic nature of people's hopes. They may have a set of hopes in the beginning, like, I want to keep my job, I want to keep working. That may be at a time where their cancer is not having great effects on them. At another point in time, the chemotherapy may ravage them so much that they can't go to work. So then we ask, what are you hoping for now in this new reality? And then they may get to a point where they are so weakened by the disease that treatment isn't possible anymore. And then, based on the prior conversations, I can ask them, what are you hoping for now? How can I help you? How can I help support you in processing the hopes you had and may no longer be your reality? And what are you hoping for moving forward? So I think that balancing act is ongoing. It's not a one-time deal, but I think it's also just reflective of human life. As our life changes, our hopes change. And so normalizing that, I think, is a big part of building rapport with a patient and family, taking their anxiety about such a discussion down a notch, and making sure that they know that these conversations are just as essential as their chemotherapy.
Dr. Puri, thank you so much. This has really been a wonderful conversation, so illuminating. And right now, I just want to mention that we will be archiving this webinar a little later today on centerforhealthjournalism.org. We'll be sending you a survey. Please share your feedback about this webinar and other topics that you'd be interested in hearing about going forward. I want to thank our wonderful speaker, Dr. Puri, and thank all of you for your smart and well-informed
Yeah.
questions.
Thank you
Thank
so
you.
much for what you're doing. Really appreciate it.